So I'll take this opportunity to start the session. Hello everyone. Once again, wonderful, warm good evening to everyone present in this meeting. I am Abhishek Kumar, Marketing Manager for Baxter Advanced Surgery India and South Asia. It's a pleasure to have all of you together with us on this, wonderful evening today, which is very close to Diwali and in some parts of the country also a Dhanteras. So best wishes to all present on this platform. Being with us is a pleasure as always. First of all, I would also extend my warm greetings on behalf of entire Baxter team, into all the eminent speakers, moderators, chief coordinator, and participants to this webinar on meningiomas. Baxter Advanced Surgery is a division dedicated towards bringing the best outcomes in surgical practice and providing the support to surgeons in achieving the hemostasis and sealing of the tissues. Now, coming to this particular webinar, this is our fourth session under the theme of Tumour Thursdays. Dr. Sridhar will talk more about it in a moment from now. This is typically scheduled for every second Thursday of each month and has been received with your kind support, nicely all across. We are proud to be associated with Dr. Sridhar as well as MGM Healthcare. And at this moment, I'll take this honor to introduce our chief coordinator for the meeting today, Dr. Sridhar. Sir is qualified for the National Board of Neurosurgery in 1990 after his graduation, MBBS from Madras Medical College in 1982. His neurosurgery training was under the pioneer neurosurgeon of India, Professor B. Ramamurthy. He also worked with Professor Ghazi Yasaragil, Professor Madidi Saimi, and Dr. K. Sugita. After taking multiple assignments in 2011, he became the director of the Institute of Neurosciences and Spinal Disorders at the Global Hospital and Health City, Chennai, setting up a neurosciences department. He has several publications, national as well as international ones, in peer-reviewed journals to his credit. He has edited multiple textbooks in neurosurgery and contributed several chapters to neurosurgical books. He has got keen interest in hands-on courses in microneurosurgery, trains young neurosurgeons. He also has got fellow in neuro-oncology, vascular neurosurgery, and spine surgery who train with him, basically. So with these notes, I will request Dr. Sridhar to take over and then take the proceedings for this meeting forward. Over to you, sir.
Thanks, Abhishek. That was quite an extensive introduction. Thank you, everybody, for coming in again. Like Abhishek said, this is our fourth session of Tumour Thursdays. These Tumour Thursday sessions were born out of, we actually had planned a brain tumor symposium in July this year with all of you coming down to Chennai, and we had planned a 2.5-day brain tumor symposium. But as things would have it, COVID played its game, and then so that was when one of my colleagues, Dr. Satish, suggested, why don't we do this like a webinar series? And therefore we started it on a second Thursday, and then it went well. And then, so what we suggested to the Baxter team was, why not we have it every second Thursday each month? And that's how it's happened. We have had multiple topics, including gliomas, intraventricular tumors, etc. And this time it's meningiomas. We try to keep the topics such that it is going to be of use to people. It's not something which are discussed every day, but it's something which neurosurgeons at large will come across, and they will have questions about how to deal with these tumors, and therefore that's how we've chosen this. So the session today. So this is my team. I would like to thank my team who have helped me, my colleagues, Dr. Satish Kannan, Dr. Vigneshwar Ravishankar, Dr. Sushant Subramaniam, who behind the scenes have been working to make this happen. We have an excellent faculty today, 5 speakers, and more importantly, 3 very seasoned moderators. Let me introduce the moderators first. The Professor Lokendra Singh is the senior consultant and Deputy Director of SIMS Hospital, Nagpur. But more importantly, he is the President of the Neurological Society of India, which is our society. And he is a very seasoned neurosurgeon. He has multiple innovations to his credit and in neurosurgery, and he thinks out of the box, very often making things simpler for all of us. So welcome, Dr. Lokendra Singh. Thank you very much for being here with us. Professor Dwaraknath Srinivas is Professor and Head of Neurosurgery at NIMHANS, Bangalore. NIMHANS is one of the premier institutes of India, and it is an institute set up only for brain-related disorders, neurology, neurosurgery, and psychiatry. And it's a great honor that Professor Dwaraknath Srinivas is here with us today. Welcome, Dr. Dwaraknath. Professor Roopesh Kumar is a senior consultant currently with the Apollo Hospitals, Chennai. He was head of department and professor at Tumour Department of Neurosurgery in Puducherry, after which he was a senior consultant at the SIMS Hospital, and then now he is with the Apollo group of hospitals, especially the Proton Center. So our three moderators will be taking the session forward. Our session, of course, has got 5 talks, which include the olfactory groove meningiomas, medial sphenoidal meningiomas, complex and parasagittal and falcine meningiomas, petroclival and foramen magnum meningiomas. So I would request all the participants to ask your questions in the Q&A box so that the moderators can see those questions and then take it forward in the discussion. We would also like to keep to time so that all the talks are well discussed and we finish the evening well before 9 p.m. Last but not the least, I will wish everybody a very happy Diwali, not only on the behalf of the Institute of Neuroscience and Spinal Disorders, but also we are hosting the first Asian Congress of Neurological Surgeons virtual international conference in December. So on behalf of that organization as well, I wish all of you a very happy Diwali. Diwali is the festival of lights right across India, and I hope that we all have a fight of good over evil and a win over the coronavirus. So thank you very much. With this, I will hand over to the moderators for taking the session forwards. Thank you.
Thank you very much, Sridhar, for a nice introduction. The only change is that some 5 years of the institute. Thanks a lot for introducing me and making me part of this very important academic activity. I think the first speaker is Dr. Sridhar. Dr. Sridhar is a very well-known person. I really need not to say much about him. Everybody knows him. Well, he's a very good friend, and he is a very important part of neurosurgical think tank in India. That this is how because he has a vision, he has some clarity of thoughts about neurosurgery, how it should be taken on national level, and that's why I respect him for that. Now, Sridhar would like to talk about olfactory groove meningiomas. Sridhar, please take over.
Yeah. Just 1 second.
Yeah.
Thank you very much once again. So I'll be talking about olfactory groove meningiomas. Now, we all know that olfactory groove meningiomas form about 9 to 13% of all intracranial meningiomas. They arise from from midline of the anterior cranial fossa, from the cryptiform plate and the frontosphenoid suture. In larger tumors, however, the attachment may extend backwards till the tuberculum cella and even laterally right above the orbits up to the sphenoid ridge. So while the main attachment is at the cribriform plate and anterior, large tumors we often see they extend quite backwards and laterally. The blood supply of these tumors is from the anterior and posterior ethmoidal arteries, the anterior branches of the middle meningeal artery, meningeal branches of the ophthalmic artery, and as the tumors become larger, small branches from the branches of the ACA and ACOM also supply these tumors. Now, the extension of these tumors into the ethmoid sinus has been reported to be in about 15% of patients, but many authors have questioned whether this is actually underestimated, and we often find, like in this patient, that the tumor actually goes right through into the ethmoid sinuses, and perhaps this number is not as high as it should be, and it is generally much more. Now, if you compare olfactory groove meningiomas with tuberculum cella meningiomas, while the location we all know is completely different, the blood supply also is a little different in that the tuberculum cella meningiomas get their blood supply mainly from the posterior ethmoidal. But very important for us surgically is that the optic nerve and chiasm is inferolateral in the olfactory groove meningiomas, while it is superolateral in the tuberculum cella meningiomas. The anterior cerebral complex is the same relation for both tumors. Clinical features wise, these patients often present with headache, personality changes, anosmia, visual impairment, raised ICP, and seizures. What is to note is that the Foster-Kennedy syndrome of unilateral optic atrophy and contralateral papilledema occurs only in a small number of patients. They are often of a very large size, and very often you have tumors which are larger than 6 centimeters in diameter right across all the literature which is there. So you could expect olfactory groove meningiomas to be generally of a large size and very uncommonly of a small size. Now, what are the surgical goals? Radical tumor excision, avoidance of new neurological morbidity, preservation of neurological function, avoidance of complications, and a good cosmetic outcome. Now, how do you decide on the ideal surgical approach? We need an approach that will give us an adequate exposure of the tumor, which can be adjusted to the tumor size and extent of the tumor with minimal brain retraction. It allows also for the reconstruction of the anterior cranial fossa base. And of course, a very important factor is the surgeon's experience and the morbidity which is related to the approach itself. So let us look at what literature says about approaches. In 2011, this paper in Romanian neurosurgery, which retrospectively studied 98 patients, 67 of which were unilateral, frontolateral, and 31 were bifrontal approaches. Now, the total postoperative mortality was 7.14%, 16% in the bifrontal group, and only 3% in the unilateral group. The causes of mortality, of course, were postoperative edema, hematoma, and pulmonary embolism. Now, the advantage of a bilateral subfrontal approach, which is a very commonly used approach for olfactory groove meningioma, is that it gives a direct access to the tumor from different perspectives. You can devascularize the tumor very early, and it gives an adequate exposure of the cranial base for reconstruction. The disadvantages are the optic nerves and the vascular structures are often visualized last. There is a large risk of CSF leak because the frontal sinuses and the skull base is all opened up. Bilateral frontal lobe injury is of importance, and you have to interrupt generally the superior sagittal sinus, which may lead to venous complications. In this paper, in Neurosurgery Focus in 2003, 13 patients were looked at between 1993 and 2003, where a bifrontal craniotomy with bilateral orbital osteotomies was done, and they claimed no complications. And they said complications which were very common in the past are now becoming infrequent. In 2007, 17 patients were looked at, also bifrontal approach, mortality 2 patients, and due to postoperative hemorrhage and pneumonia, and a list of morbidity was also seen. So one comes then to the unilateral subfrontal approach to see how it is advantageous. Now the advantages is that it spares the superior sagittal sinus, it spares one side of the frontal lobe, but the disadvantages of the CSF leak still continue, and a unilateral injury to the frontal lobe still is there. Now, this is a very important paper which came in Turkish neurosurgery in 2012, where they looked at 42 patients with the mean diameter of the tumors to be between 5.6 to 8 centimeters. They achieved a total excision in 97.6%, but had a 23% complication rate. Now, they then looked at the size versus complications, and as can be expected, the larger the size, the more were the complications. But looking at how they were managed and what actually happened, the intracerebral bleeding in one patient and the ACA infarct were basically the two complications which actually were problematic complications. The others were all problems which could be treated. Recently, the pterional approach is becoming more and more popular, even for the olfactory groove meningiomas. The advantages are the early CSF release, early visualization of critical structures, minimal frontal lobe injury, and a lower risk of CSF leak because you do not open the frontal sinuses as far as possible because your approach is more lateral. However, the disadvantage is that it gives poor access to the upper and contralateral parts of the tumor. In 1999, in skull-base surgery, Dialwad, they addressed the suitability of the pterional approach to giant olfactory groove meningiomas, and they said it had two specific advantages. One is minimizing retraction, and second is to allow an earlier control of the neurovascular structures from the tumor's posterior pole. In 2013, Bitter et al. Then showed how these tumors could be removed using a pterional approach based on a 20-year experience, and is diagrammatically shown on how through a pterional approach, they would first go to the posterior aspect of the tumor, releasing the ICA, and then do the devascularization and finally go to the upper pole. However, they had one mortality due to pulmonary embolism, and then a 26% morbidity due to a series of different causes of morbidity. If you look now at the various retrospective studies according to operative technique, you can see that there is a vast difference of how different people use different techniques, which highlights the point that actually there is no one technique which has been accepted as, yes, this is the technique for olfactory groove meningiomas. Anil Nanda and his team, they looked at, in world neurosurgery, they looked at the extent of frontal lobe changes after unilateral and bifrontal approaches. And then they found that the lateral approaches resulted in less frontal damage and better olfactory preservation in comparison to anterior approaches. Once again, how you do the tumor is first, you would look at the ICA and the ACA, and then do the devascularization, and then finally go to the upper pole, just like in the paper by Bitter et al. Now, skull-base approaches have been used for the olfactory groove meningiomas. Of course, we all know that it results in less brain retraction and access to extracranial extension, but of course, it is a high procedure-related morbidity is there. Endoscopic approaches have been used, again, with the avoidance of brain retraction, early tumor devascularization, direct tumor access. However, there is a high risk of CSF leak with a steep learning curve and a high morbidity when there is a low experience. The only, while olfactory groove meningiomas in many papers have been shown to be advantageous, the problem is that it is not suitable when the dural attachment extends laterally over the orbital roof and along the lesser wing of sphenoid. And the reconstruction of the large anterior skull base defects is a challenge still. Postoperative olfactory function in these tumors is a problem when the tumor was more than 3 centimeters. Now, you can preserve olfaction if preoperative osmia, that is, if the patient has had olfaction sense before surgery. So you could preserve it in the contralateral side, but preserving it ipsilateral to the tumor is very, very difficult, irrespective of tumor size or surgical approach. Atul Goyal et al. From Mumbai analyzed 129 cases and established a grading system based on various factors. And this is a very extensive grading system. And they divided the tumors into 3 grades based on the points that you got on the grading system, saying how difficult it would be and the rate of morbidity that you would expect. They did bifrontal craniotomy in 41 patients and a unilateral craniotomy in 88 patients. But after 2014, all cases were operated only using a unifrontal approach, and no extended skull base or endoscopic approach was used in their series. A very important point, what was mentioned in that paper, was that polar brain resection anterior to the tumor can provide an effective quick exposure. And this is something which we remember being taught in our generation to do this when there is just a thin bit of frontal lobe covering the tumor. And this is something which I think is a very, very important point. My personal series is 22 cases with an age range of 35 to 60 years. My preference is for bifrontal approach because vast majority were large tumors. I would do a bifrontal approach with the patient supine, a large bicoronal flap, and then approach the tumor first from the right side, devascularize, and then from the left side, and then devascularize the tumor. If it is a tumor like this, where you're more of a unilateral tumor with a little bit of extension on the opposite side, I would then do a unifrontal approach and then remove the tumor accordingly, according to the same principles. Now, I always felt that the classical pterional approach with a flap like this was not adequate as far as olfactory groove meningiomas are concerned. This is because the olfactory groove meningiomas attachment is further medial, and therefore what I currently do for olfactory groove meningiomas when I use the pterional approach is do an extended pterional, extend the craniotomy to the more frontal up to the midline, and do a craniotomy like that so that I can reach the cribriform plate and get the tumor from its attachment. So like I said, preference is for bifrontal tumors, but what now I do for all these tumors is expose the sylvian fissure on both sides so that you can open the sylvian fissure and then go from a lateral frontal approach after the brain is lax and you let out CSF, and then you also have control over the neurovascular structure. So it is more of a modification of the classical bifrontal approach than using a pterional or a unifrontal approach. This is a case done a few years ago. This man was in 2006, it was operated. This man was a hemophilic actually. People refused. This is the scalp flap that I use so that I have enough. You see the large frontal sinus. So you need to reconstruct the base. This is the craniotomy that is done. And this is in 2019. He's doing well with no recurrence. Now in this patient with an intensely enhancing lesion, bifrontal interhemispheric approach, we did the craniotomy. The tumor was found to be extremely vascular, so we stopped. We embolized the tumor after that, whatever we could, and then went in later at a second stage and then removed the tumor. We've used the pterional approach in cases like this where the tumor is more on one side. So a pterional approach with a flap, like I said, going to the midline of the frontal lobe. And in this, this is a short video. So open the sylvian fissure first, widely. This is the temporal lobe, the frontal lobe. And once that is done, I always devascularize the tumor first. While authors have said, like Anil Nanda and Bitter, that you could first go posterior, I somehow feel that tuberculum cellular meningiomas are better devascularized, so that you get a tumor like this, which you can just go and cut off and debulk very fast. And that's why I devascularize the tumor. And then you would see the optic nerve there infralaterally. And then the tumor comes off the optic nerve. And then you come posteriorly and medially. That's where you would expect to see vessels. So you would start by seeing the branches of the ACA. And as you remove more and more tumor and debulk it, you would slowly then see the rest of the ACA branches. And as you remove the tumor. So this is the last of the tumor attachment there, which is going right up to the back of the tuberculum sella. And there you see the branches of the ACA here. This is the branches of the ACA, which are related posteriorly, and then you would have to dissect that very carefully to remove the tumor. So these are the branches which then you would have to dissect and remove. So this patient, this is the immediate post-operative period. The patient did well and went back to Sri Lanka, which is their hometown. This particular lady came with 50-year-old loss of smell seizures and frontal lobe signs. This was operated again through a bifrontal approach from Myanmar, and they have done, she's done very well. We had one mortality with this giant tumor. It was a very vascular tumor which started bulging into our face. We somehow got control, but very turbulent postoperative period, and we lost the patient after a week. So in conclusion, olfactory groove meningiomas are relatively uncommon, and we need to plan the operative management using an approach which is best suited to the tumor and the surgeon. Try to preserve at least one olfactory tract if possible. The ACA complex needs careful dissection, is related posterior to the tumor, and therefore one has to carefully dissect it out. Use of skull base and microsurgical principles helps to reduce morbidity and mortality. And very, very important after doing a major surgery is reconstruction of the skull base. Thank you very much, and I would invite all of you to the first ACNS virtual conference. Thank you so much. Dr. Lokendra, you are muted.
Yeah. Thank you very much for a very lucid presentation and sharing your vast experience of very huge giant tumors with all of us. I can't see any questions here. Let me ask few questions. Is there anybody doing endoscopic procedures in your department? Endoscopic excisions of these tumors?
No. As far as we are very comfortable doing the meningiomas transcranially, we are not doing endoscopic excision of anterior skull base meningiomas.
There is one more approach is there which nobody talks actually about that approach, and I have used that approach in around 13 to 14 patients. It is very suitable to patients which are arising from the part of olfactory groove, but very near to crista galli, there. And the transglabellar approach, I've really not read much about it. It is mentioned in literature. I used in around 13 patients. In suitable cases, somehow I found it very good. There might be an objection that, you don't see other when you operate through endoscopic procedure. So I don't know, in my hands, that is giving very good results. and I have never repented using it. One more thing I would like to ask. How you decide the extent of tumor excision? Do you consider the perilesional edema? How much is the edema? Do you take that as a yardstick that you have to be more aggressive and you would like to increase the Simpson grade? You know, you would like to go for dural excision and bony drilling, etc., and then try to reconstruct the anterior fossa. Do you change your strategy according to?
The extent of edema in the frontal lobes, what we have seen generally in all our cases is that all these large tumors have a lot of edema in both frontal lobes, and generally it subsides once you remove the tumor. That is first thing. Second thing is that does not dictate the aggressive or radicalness of tumor removal. What we do is, of course, the tumor is removed. As far as the attachment area, what I try to do is remove whatever dura comes off. I don't drill the base. I don't drill the bone off. I don't do that because I don't do that.
Okay.
Unless just one thing. Unless you have tumors which are going in the MRI into the ethmoid sinus and I need to access to get that tumor out, then I may do a little bit of drilling just to widen the opening so that just to remove that tumor. But I do not remove the anterior skull base just to get a better Simpson grading.
One question by Malay Chakravarti. Yeah, just one question I think. Do you use CUSA and how frequently and how much you use CUSA for this surgery?
Okay, many of these tumors, what I have operated are very firm and not CUSA-able tumors. But when we find a soft area, we do use the CUSA. It depends on the consistency of the tumor rather than having to use it all the time. The CUSA is there, so we use it whenever we think that it's going to be of use. Yeah.
Thank you. I think thank you very much,
Dr. Lokendra, there is one more question in the chat box from Dr. Gilbert Korer. Yeah.
Which approach is good in case of high-grade glioma? I think this is not related with the
meningioma.
Actually.
Yeah. So we will reply to him on the chat itself.
Yeah, I think so.
Yeah.
Yeah. Okay. Thank you, Sri. Thanks a lot. Now, may I invite Dr. Tetsuro Sameshima from Japan, and he will talk about the medial sphenoid vein meningioma.
Hello, can you hear me?
Yeah, you're okay.
Hello, okay.
You're fine.
Thank you very much. Including me, my name is Tetsuro Sameshima, Hamamatsu University School of Medicine, Shizuoka Prefecture in Japan. So actually, my subspecialty is skull-based surgery, especially for skull-based tumor and difficult aneurysm after coiling and also compressing in the brainstem, thrombose huge aneurysm. And so this is my last year's skull-based meningioma, my experience, over 200 cases. My favorite meningioma is a posterior fossa meningioma, especially for petroclival, CP angle, petrotentorial, and foramen magnum. So, especially one of my favorite surgery is the combined transpetral approach for this kind of huge petroclival meningioma. However, also, fortunately, I have some patients from overseas This this girl is from India, and so I have some experience in the surgery in the foreign countries. So this picture with Professor Kato's colleague, good guys. So today, you guys gave me this title, medial spinal meningioma. So let me show you 2 video clips. First one is a medial spinal ridge meningioma, and the second one is tubercular meningioma. So this patient is a 71 female with a visual disturbance. So I choose just a simple right side frontotemporal craniotomy. Let me show you a video clips. So this tumor, I can not see anything. So I'm performing as much as possible and the internal debarking. And then finally, I can see the right side optic nerve. I'm trying to detach from the tumor. The most important thing is to preserve the small vessels on the optic nerve to preserve that visual function. So this is the right side on the lateral side of the optic nerve. So this is you can see this is the right side carotid, the anterocoroidal, and the A1, and this is a chiasm, right side optic nerve, and then so I'm looking for the PCOM. So can you see the PCOM? And then I'm detaching from the attachment of the medial spinal ridge. Also, I'm trying to perform the devascularization. This. So you can see it over here there on the stalk, pituitary stalk. And then I can move the tumor easily, much more easier, like this. And still, we have to take care of the small perforators from the carotid. So you can see the small carotid. So this is an oculomotor. This tumor already embedded into the pulse oculomotoris. And then so I'm looking also removing the tumor remnant in the pulse oculomotoris, like this. And then so see that? And then so this is the right side carotid. So also this tumor embedded under the carotid. I'm trying to remove that totally like this. Still, I have a small remnant of the tumor like this. So I'm trying to elevate the tumor capsule from the surface of the brain, also brain stem. So we have to preserve the small vessels of the, the perforators. This is the final view. It's a right side carotid, PCOM, anterocoroidal, M1, A1, chiasm, the stalk, and the basilar artery, and the oculomotor, SCA, and so on. So this is the final view. This is a post-operative MRI. This patient with disturbance and improved to the almost normal. So this also medial spinal ridge meningioma. I performed the surgery using the same technique. So this patient right side visualization is recovered to the almost normal. The next video clip is a tubercular meningioma. This patient is a 57-year-old guys. This patient complained was also visual disturbance, especially left side. So I choose left front temporal craniotomy. So let me show you a surgical clip. And first of all, I did anterior cranioidectomy and optic canal decompression. And I'm going to the inside on the dura, and I'm looking for the optic nerve. This is the left side optic nerve and the carotid here. You can see the tumor in here and here. So, okay. So this is the left side of the nerve. So the tumor also are embedded in the optic sheath like this. So that I'm elevating a tumor from the IC, dorsal wall IC, and also optic nerve like this. So this is the left side optic nerve. I'm separating from the medial side of optic nerve, and then also detaching from the tuberculum zerae here. So I'm coagulation, tuberculum zerae, and still tumor is here under the carotid and IC and the optic nerve. And then I'm performing internal developing using a Kusa. And then finally, I can detach from the medial side of the left optic nerve and also right side and the left side. And then I remove the finally. You can see the small vessels as superior hypophyseal artery. So you can see the stalk here on left side. So this is the final view of the, and this is the post-operative MRI. So this patient, the left side visualization will recover to the almost normal. Thank you for your attention. Thank you very much.
Thank you, Dr. Sameshima.
Mm-hmm.
I have a question.
Yes.
Yeah. So for the spinoid meningiomas with the vascular encasement, what is your strategy? Those meningiomas which has, especially in the medial sphenoid wing, these meningiomas tend to have a lot of vascular encasement.
Yes.
Yeah. So what is your strategical strategy?
It depends on the adhesion to the carotid and the optic nerve. So usually in the first surgery, I can separate from the also important structure of the carotid and the optic nerve. I think it's not so difficult. Yes, almost.
Not many cases will have. Many times it goes around the perforators and ICA. So how do you dissect the vessels from the tumor? Are you aggressive or you leave a thin cuff of tumor around the vessels?
Yeah, the most important thing using a micro scissors. Don't pull strongly. I mean the sharp dissection as much as possible.
Do you do extradural clinoidectomy in medial sphenoid meningioma?
Yes. Extradural, just only an anteroclinodectomy and the optic canal decompression. I do the I perform it from the extradural. But except them, and I do everything intradurally.
Okay. Do you follow the vessels from lateral to medial or medial to lateral? You identify the ICA and then you trace the tumor, or you identify the middle cerebral artery in the salient fissure and go towards the ICA? How do you decide?
I don't know. But, I think it's not so different, I don't know, but it's not different for me.
Okay.
That was a very nice talk, Professor Sameshima. I have two, three questions for you. One is, how frequently do you encounter in your practice these very hard tumors which are not suckable by CUSA? And then what is your strategy for these tumors? Do you try doing total excision or leave some tumor behind? And second thing is, have you ever used a bypass to bypass the circulation and then go for gross total excision, or what is your strategy for these very hard tumors?
Yeah, if tumor involved to the medial perforator from the MCA to prevent the hemoparesis. If tumor involving to the some perforator from the MCA, I do bypass surgery first, and then I try to remove that.
So, but what about
Dr.
this?
Sameshima, can you please?
Sorry, sir. What about these very hard tumors?
How the tumor?
Yeah, which are not CUSA suckable.
Yeah. Some I have some experience. It's very difficult to use a CUSA for a very hard tumor, and especially for include with calcification. But such cases, I use very hard scissors to cut the, I don't know what to say. They're very strong scissors. I use it.
Dr. Dwaraknath.
There is a question from the delegates. Dr. Lokendra, can you just have a look?
Yeah. Actually, this question is by Nidhi Yadav. How you start decompressing, intradural or extradural in case of medial stenoid wing meningioma? So you start excising the tumor intradurally or extradurally?
Intradurally.
That's a question for you, Dr.
Yeah, intradurally.
Intradurally.
Yes.
I have one question. Do you differentiate between cell meningioma and clinoidal meningioma? Or you just club them into medial stenoid and treat them the way you treat every meningioma in the same fashion? Or you try to devascularize them differently because the blood supply might be different? Is there any difference in the strategy while excising the clinoidal, anterior clinoidal meningioma and tuberculum meningioma, Do you differentiate?
Actually, I'm sorry, I don't hear you not so well. But I usually perform the anterior clinoidectomy from extradural first.
Okay.
I mean that it means detach devascularization. I mean that so for clinoid meningioma and the medial spinal ditch meningioma.
So first you go extradurally, drill off the anticlinoid process, devascularize the tumor, then go intradurally.
Yes, exactly.
Can we move on to the next?
Extradurally. Tuberculum meningioma. Yeah.
Sridhar?
Yeah. Yes, Vernon. Yes, please.
No, the question which Roopesh had asked, and I think Dwaraknath has also asked, see, in our setup, we see a lot of very hard tumors, sometimes calcified like bone.
Yes.
So CUSA is of no use for these tumors.
Yeah.
Even the scissors does not cut. Even the scissors, a good scissors, a tough scissors, and bomb scissors. Okay, it comes in handy to cut tumors. But many times I've seen that even a number 15 blade, a scalpel blade, can shave the tumor. And that is what we do. And the question which Roopesh asked, if the tumor is invading the adventitia of the ICA, or if it is attached to the adventitia, then it is a dangerous thing to try to dissect it, in my opinion. I would preferably leave it behind.
Okay. Thank you.
Dwarka, can we go ahead?
Yeah. Thank you, Professor Sameshima. Wonderful talk. I would like now to invite Dr. Dilip Panickar. Dr. Dilip Panickar, of course, has been a stalwart of neurosurgery in India, first at Chitra and then Amrita, and now he is the consultant neurosurgeon and head of neurosurgery at Aster at Kochi. He'll be speaking on complex parasagittal and falcine meningiomas. Dr. Panickar, please.
Thank you, Dwarka. And let me share my screen. There we go. Okay, can you see my screen? You?
Yeah, we can.
Yes, okay, thank you. So, the parasagittal and falcine meningiomas, Sridhar gave me the topic of a complex parasagittal. This because by and large, because of their location and because of their inherent growth pattern, tumors in this location do tend to be more difficult to manage than the conventional meningioma. So I would drop the complex part of it. So a bit of the background. This is one of the more common locations for origin of intracranial meningiomas. Apart from convexity meningioma, this is probably the next most common type or the location where intracranial meningiomas occur. Statistics say that they form about 21 to 31% of intracranial meningiomas, that the parasagittal meningiomas. The falcine meningiomas are much less common than this, fortunately. They're only about 8.5%. And what is interesting is they have a propensity to become bilateral tumors, both of them, the parasagittal as well as the falcine meningiomas, which adds to the problems that the surgeon encounters when dealing with these tumors. These tumors traditionally are grouped, are classified based on their location in relation to the forks along its length. Very simply, the anterior third or the middle third or the posterior third in relation to the sutures, the frontal base to the coronal suture, coronal to lambdoid, and the lambdoid to the back, to the torcula, towards the end of the forks. Both the parasagittal and the falcine meningiomas are are grouped based on this. Yassergesell has also given another grouping for falcine meningiomas as the outer and the inner. Though we don't encounter this grouping very frequently, it's mainly and very simply put, the thirds. The outer falcine meningiomas arising on the main body of the forks, where the inner falcine meningiomas arising in conjunction with the inferior sagittal sinus, which runs along the free edge of the forks. So, what makes these tumors very unique is its relation to the venous system and their propensity to either adhere to or encase or invade the venous structures. These are the cortical bridging veins that jump off the medial edge of the hemisphere and drain into the superior sagittal sinus or into the sagittal sinus itself. This is what makes these tumors by and large complex and gives rise to a lot of the problems that go along with the management. It's estimated that up to 15% of the tumors present with, especially parasagittal tumors, present with major sinus invasion or occlusion. Though, again, this number is probably underestimated. When we talk of the sinus, there are different, the extent to which these tumors involve the sinus has been very elegantly described and classified by different authors, the most common of them being the Sindhu and Bonal and Broche classifications. Essentially, what it does is it indicates how far the sinus is involved, starting from the very corner, the lateral angle, or just an adherence to the lateral wall of the sinus, which is probably the lowest grade in both these classifications, going all the way to involvement to encroachment into the lumen, involvement of one or two walls, involvement of all three walls, and complete occlusion and going bilaterally. So the grades, as it progresses through the various stages, as one can well imagine, the complexity of involvement also changes. The sagittal sinus being a very important structure, and especially in the middle and posterior third, there is a great, and it is imperative to preserve the sinus, except in situations in very, very high grade involvement where there is a complete occlusion of the sinus. And we will discuss this a little later. A word regarding the histology. This is again very interesting here. The majority of these tumors, as with most meningiomas, are grade 1 tumors, which fairly well behaved. However, the proportion of higher grade tumors at these locations, at the parasagittal and falcine locations, are reported to be higher than at other locations. So generally the tumors along the convexity tend to be more aggressive and slightly of a higher grade as compared to the tumors of the skull base, which tend to be more indolent, even they are much more complex and difficult to treat. And among the convexity tumors, the parasagittal and falx again tend to be a little more aggressive. A possible reason for this has been described in terms of the mutation of the H3K27ME3 gene, which is supposed to increase NF2 mutation and correlate with more aggressive tumor behavior, increased recurrence and malignant transformation. And this frequency is supposed to be higher in parasagittal meningiomas as compared to tumors in other locations. As with most meningioma, these tumors can present either with a focal neurological deficit, raised intracranial pressure, and a fairly high incidence of seizures. Depending on the location, the symptom complexes may change depending on the anterior third, which present more with cognitive deficits and the personality changes. And as it comes to the middle third, increasingly you have motor deficits and seizures. And with the posterior third, more with visuospatial, more with visual abnormalities like hemianopias and other visual issues. Headache is commonly seen across the different groups. Imaging is very important. I mean, for diagnosis, all three forms of imaging have a very important role in these tumors. The CT scans showing the bone changes over the tumor, the hyperostosis or the bone erosion. The MRI scans, again, the specific points in these tumors with relation to the MRI scans are is the anatomy of the deep venous system and the status of the the venous system, especially the superior sagittal sinus, the cortical draining veins, and the location and distribution of the cortical veins in relation to the tumor, which is very important when planning surgery. Venography is very important and has to be done in all these tumors. And whenever there is a very high grade occlusion or invasion of the sinus, doing an angiography is likely to be of great help to demonstrate or to confirm sinus occlusion and to know the state of the cortical veins and very importantly to plan surgery, the collateral channels, the collateral venous channels. The management, as would be expected, surgery is the most important step, and one aims for a gross total excision, as with any other meningioma, including the involved dura, which is optimal, but in this particular location, in the parasagittal location, is not feasible because of the attachment to the sinus or involvement of the sinus. With a falcine meningioma, the pure falcine meningioma, a symptoms grade 1 excision is possible because of it is possible to excise the involved forks around the attachment of the tumor and thus remove the tumor and the attachment completely. The limitations, again, apart from the involvement of the sinus, are the cortical bridging veins, which in a parasagittal meningioma can either run over can overlay the tumor and come in way of the surgery, or can be involved by the tumor, or in case of a falcine meningioma, the gap between the space available between the cortical bridging veins often makes the surgery either very simple or very difficult. A few points about the technique here. Positioning in the anterior meningiomas is largely supine with head elevation. With the posterior meningiomas, they can be done prone, but with the middle third meningiomas, one can either adopt a semi-sitting position, or it may be optimal to use a lateral position with the ipsilateral hemisphere lying dependent to allow for a gravity-assisted retraction and to open up the space and to minimize the need for retraction. Navigation is of great help in planning the surgical approach, planning the bone flap, which should be adequate. Now, surgery of these convexity meningiomas along the calvarium is not minimally invasive surgery. One generally needs a very good bony exposure, and in these tumors going across the midline to expose the sinus as well. ICG has been recommended prior to dural opening to identify the location of the cortical bridging veins and to plan the dural opening accordingly. Dural opening, the dura is generally hitched medially or raised medially. But if the bridging veins are attached to the dura, one cuts the dura parallel to the bridging veins and leaves the strips of dura attached to the veins so as not to put traction on them. After tumor removal, closure is very important. Usually, if the dura is either shrunk or deficient or excised, a patch would need to be used to close it. These are some schematics showing the dural opening and the tumor removal. As you can see here, if there are bridging veins that are adjacent, that are running along the dura, incisions can be made in the dura parallel to the bridging vein, and leaving a small flap of dura attached to the vein to prevent traction on these vessels. As with any other meningioma, the dissection of the tumor from the brain is very important. Maintaining the arachnoid plane at all times is imperative. That does not change irrespective of the location of the tumor. Similarly, some of these tumors tend to be very lobulated, in which case one can find vessels running between the lobules, and they have to be very, very carefully dissected away. So this is very typically a short video clip. I will quickly run through it. This is a vein. As you can see, this is overlying the tumor and is very, very important to preserve and dissect the vein. The dura is raised laterally, and a very important maneuver is to free up the vein by gently releasing the arachnoid around the vein so that you reduce the tethering effect on the vein, reduce the traction on the vein as you manipulate the tumor, and allows the vein to remain free as you can work below it. So a gentle removal of the arachnoid, and as has been emphasized by other authors, the sharp dissection is very, very important. There is no role for a blunt dissection here. And once this is done, the veins are freed. Again, the principles of meningioma surgery apply: dissection from the brain, detachment of the tumor from the origin, and progressively and a gradual removal of the tumor. With falcine meningiomas, this is what I told you. One can start the surgery by dividing the forks around the attachment of the tumor. And this allows the tumor not only to be devascularized, but also takes off the attachment completely, which can be removed along with the tumor, and thus achieving a complete excision, which is not possible in the parasagittal location. A word about how to handle the bridging veins. Can the bridging veins be sacrificed? Generally, no. It is said that sometimes the more anterior bridging veins can be sacrificed, but no, it is important to preserve all the bridging veins as far as possible, the risk being either severe brain edema or a venous infarct. Again, one cannot emphasize enough the need to study the preoperative venography or the DSA to identify the anatomy of the bridging veins. There are described techniques to determine the intraoperative direction of flow. However, by using intravenous fluorescein or ICG, and by applying a temporary clip on the vein at its junction, at its entry into the sinus, and to see if there is any alternative, if there is any stasis of dye within the vein, which indicates this vein cannot be sacrificed. However, if there are venous collaterals that exist that permit a drainage through other routes, and the dye is seen to flow, then yes, as a calculated risk, the vein can be sacrificed. So again, the need for sharp dissection to carefully free the vein from the tumor. And if one finds that the tumor is very adherent to the vein, it is prudent to leave a small sliver of tumor around the vein to protect it. With regard to the sinus, the management depends on whether the sinus is completely occluded or partially patent. If it is completely occluded, then, and this is confirmed by either intraoperative Doppler or by intraoperative ICG or fluorescein video angiography, then the occluded sinus can be excised. However, what is important to understand that as a sinus gets occluded, there are collateral venous channels that develop, and the careful study of the preoperative imaging is important to understand where the collateral venous channels are, and it's very important to protect and preserve them, or else one can again lead to severe brain edema and venous infarction. The more anterior the sinus is occluded or involved, it is possible to excise it or excise the sinus with proportionately with a minimal amount of morbidity. But however, one should make an effort to protect the sinus at all times. Even with excision of a completely occluded sinus, there is a reported 1 to 3% risk of mortality from venous hypertension and brain swelling. The problems lie in a partially patent sinus with minimal involvement with the lower grades of involvement, which is just the lateral wall, adherent to the lateral wall, or just tumor invading the lateral corner of the sinus. It is safely possible to excise the edge and to reconstruct the sinus with sutures. However, with higher grade involvement, there are techniques described where one can open the entire sinus between temporary clips, or with Fogarty catheters, or with patties placed into the sinus lumen on either side, and reconstruct the sinus using pericranium. However, these are very elaborate, complex techniques and do have a lot of morbidity. Again, there's a bit of controversy with regard to this. I will refer to that later. Bone invasion is very important to understand and address. Minimal degrees of bone invasion, if it's partial thickness, the involved bone can be drilled off, leaving the outer table intact. However, if it is a full thickness involvement, one will need to excise the full thickness of the bone. And if it is a large area of involvement, there will be a substantial bone loss, which will need to be replaced with a primary cranioplasty using a titanium mesh, or with or without methyl methacrylate, and or a custom-made cranioplasty if this is pre-planned. Though all meningiomas, all tumor surgeries are associated with complications, it is reported that meningiomas in the parasagittal and the falcine locations have a slightly higher incidence of complications, reportedly up to 19%, with various kinds of issues. The biggest problem being venous infarction. Again, it's all related to the venous system and how the tumor affects the venous system. And there are various ways that have been described to avoid or to minimize the incidence of complications, but all this involved very, very meticulous, systematic preoperative evaluation and intraoperative management. Post-operatively, it's very important to maintain adequate hydration, because even a bit of dehydration can cause a vein that is slightly compromised to thrombose and lead to delayed problems for the patient. The role of radiation therapy is very important here, especially with tumors like the parasagittal location, where there is often residual tumor. And either conventional fractionated or now what is more common, stereotactic radiosurgery is very effective in controlling the growth of these residual tumors. When is it used? Either in very small tumors, which are shown to be growing as primary treatment modality. in residual or recurrent grade 1 tumors, in tumors that have an atypical or anaplastic histology. And again, this is something that's interesting, in tumors that are shown to be EGFR negative on IHC, or which have a MIB1 labeling index of greater than 10%, even with a gross total resection, where there is a very high probability of recurrence in these tumors. Radiation is very often used along as a complementary technique to surgery, where surgery is used as a tailored resection with a small remaining fragment that becomes amenable to radiosurgery. Where do the controversies lie is regard to management of the sinus. Even though there are a number of techniques described for opening and reconstructing the sinus, there is still a controversy. Does it really need to be done with very strong proponents of sinus opening and of aggressive sinus surgery with reconstruction? And people and papers like Matheson who have shown that even with very aggressive sinus excision and reconstruction, the tumor recurrence is still very high, and that does not preclude the need for postoperative radiation in many of these people. A few examples here. This is a young man with a large tumor. You can see the extent of calvarial involvement here. This gentleman underwent surgery and replacement with a large titanium mesh. To reconstruct this, there was a bit of tumor that was remaining in the sinus that was left behind, subsequently grew, and he subsequently went on to have radiation therapy for this and is now stable. This is another young lady with a large parasagittal meningioma. At the end of the first surgery, there was a vein that was running right over the tumor, and we seem to have missed a small fragment of tumor that we discovered on a postoperative imaging, which was followed up sequentially. However, a couple of years later, it started growing, and this lady underwent postoperative radiosurgery. But after the radiosurgery, she developed severe brain edema and had status epilepticus and developed a severe hemiparesis, which was sort of refractory to treatment. She was stabilized medically and continued to follow up. However, she continued to worsen. The edema increased, and eventually she had resection of this part. The moment this tumor was resected, everything settled. The seizures disappeared, the edema disappeared, and 3 years down the line, she continues to remain very, very well. So this indicates the need for sequential treatment and the close follow-up of all these patients. What is the take-home message? That these are common tumors, and almost invariably, most surgeons will encounter these tumors at some point or the other. The management is complex because of the anatomy and the location and the invasion and the behavior of these tumors. A very, very detailed study of preoperative anatomy and the venous anatomy is very important for an optimal management. And a combination of surgery and, as necessary, radiation therapy gives you the optimal results and good tumor control. Thank you very much.
Thank you, Dr. Panickar. As usual, it's been a pleasure to listen to you. I have a few questions for you.
Absolutely.
One is that you mentioned opening of the vein. One is the opening of the venous sinuses. Do you do it as a routine, or do you reserve it for special situations? And if you open the sinuses, do you do a monitoring, or do you use a venous bypass while you're handling the sinuses?
Okay, I have just told you what is there in literature. My personal practice is to limit the sinus opening to only tumors that invade the lateral wall of the sinus, where they can be removed and the sinus reconstructed with sutures without occluding the sinus. For any tumors that is a higher grade involvement of the sinus, I personally do not. I would rather be conservative and protect these people and leave radiosurgery to manage the rest. So I do not, I know that there are others who are very aggressive on the sinuses, but I do not. I think that probably in my hands, the morbidity would probably be higher. So I would prefer the combination with a good radiosurgery at the end of it.
Another question was on the fall sign meningiomas.
Yeah.
There's been a little talk about contralateral approaches to falcine meningiomas.
Yes.
Take on that.
Contralateral approaches are, but again, it all depends on where the veins are. Falcine meningiomas, because they are completely free from the surface, one gives, and you can work through the forks entirely. So depending on where the veins give you a better access, one can use that corridor and get in through there, cut the forks around the attachment of the tumor. Now, very often falcine meningiomas are bilateral. They do extend to the other side. The other side may be a very small nubbin. But if you just follow that, you will see that nubbin, cut around that, and you will reach a larger bulk of the tumor on the other side. If they're purely unilateral, one can use navigation to see where the attachment is and then cut through the forks right there. What I prefer is what I have increasingly come to prefer is the lateral approach for these people with the ipsilateral hemisphere down, with the side of approach inferiorly, which allows a beautiful gravity-aided retraction and really opens up the corridor. And if you have tumor on the other side, as you cut the forks, your tumor keeps getting delivered into your field, which is actually a very nice way.
I don't see we have any questions from the audience.
I have a question, Dr. Dwaraknath. So,
yeah, Roopesh.
Yes. So again, it's a very interesting talk, and because you touched upon the radiation, the radiosurgery, just want to know now that there are a lot of enthusiasm more than EGFR. I think the third promoter mutations in meningioma. So third promoters. So any meningioma, if they have third promoter, there's an indication for an upfront radiotherapy. Then wait and watch. Just wanted to add that fact.
Yeah. No, I completely agree with you. I think as with gliomas, the understanding of the genetics of meningioma, the molecular genetics of meningioma is rapidly increasing, and there are a whole lot of mutations and changes that are being described. And some of them, like you rightly say, with the third promoter, which do have a propensity for a much more rapid recurrence and aggressive behavior. So those are fun that you treat upfront. I completely agree with you on that.
And even then, indication for grade 2 meningiomas, atypical. So nowadays there are a lot of interest that previously we used to do at recurrence. Radiation we'll consider at recurrence, but then again now there is a lot of enthusiasm on upfront radiation for atypical meningioma, especially if the pathologist says there is brain invasion. So what is your take on that?
See, if there is brain invasion, certainly yes. You do need to give an upfront radiation, not to wait. The issue comes when you have the moderate-sized tumor and your pathologist reports that there are focal changes of grade 2 within the tumor. Then how do you deal with them? Where your periphery is intact, it has not yet invaded the brain. Then what do you do? Do you give radiation to them? That is one category where your pathologist says that there are focal changes of grade 2, which technically would make it a grade 2 tumor. But there are focal changes, the periphery is not involved, there is no brain invasion, in which case there is probably a role for a wait and watch in that group of patients. However, very interestingly, even with lower grade tumors, there is a paper by Matheson, which I had referred to, where they say that in their large group of patients, the results of upfront radiation for residual tumors was much better than the results of wait and watch and radiation on recurrence. They were not able to explain why, but then they have noticed this very clearly. So again, I think it's a debatable issue, but and I think there is going to be a bit of variability on this.
Thank you, Dr. Panickar, and I think we'll move on to the next talk. This is by my good friend Dr. Sumit, and he was formerly Professor of Neurosurgery at the All India Institute at New Delhi, and right now he's Senior Consultant Neurosurgeon and Director Neurosurgery at Paras Hospitals. Dr. Sumit.
Professor Dwarka, thank you so much for that wonderful introduction, and I thank Professor Sridhar for giving me this opportunity to give me some moments where I can share my little experience and be an opportunity to educate the young delegates over here. So my next few minutes will be on this formidable meningiomas, I mean, which every skull-based surgeon should know as to how to deal with these terrific tumors. And I will be taking you through small videos, 2 or 3 of videos, depending on how much time I have. And of course, about a little thing about as to how to decide the operative approach. And needless to say, my majority of my focus of the center of my talk will be, of course, on the keyhole approach to these lesions, because I, being mostly a keyhole and endoscopic surgeon, so basically what I am trying to, the philosophy of this talk is to drift away from the conventional skull-based approaches towards the minimally invasive and keyhole approaches as applied to these tumors. So to start with, the petroclival meningiomas is a term which is very specifically applied to those tumors which arise from the upper 2/3 of the clivus and are located at the petroclival junction, arise from the junction dura, and are projecting medial to the fifth nerve. So this is a very peculiar, specific, strict classification of petroclivals. But in literature, we see extension of these areas, and which several authors have, commented on petroclival, sphenopetroclival, petroclivo-sphenoidal, as I will show you in a short while in my talk. So one has to be wary of using these terms very specifically. And for my purpose of this talk, in this talk, I have included everything which arises near the petroclival dura as petroclival meningiomas, and also an extension into the sphenoid sinus, sphenopetroclival, petroclivo-sphenoidal, and clival meningiomas into the same category, because the surgical selection depends on where the predominant area of the tumor is. So these tumors, the problem of these tumors has been well documented in literature. As you can see, these all accomplished surgeons, they have so much of cranial nerve deficits with a mortality rate of varying from 0 to 3.7%, and the less gross total resections also. So coming straight away to the selection of the operative approach, the conventional skull-based literature is full of traditional approaches: anterior petrosal, FTOZ, posterior petrosal, combined petrosal, and whatnot. Big approaches in order to, with the basic common goal of complete excision of the tumor with minimal brain retraction and minimal cranial nerve damage. So there is an indication for each of these approaches. If I broadly and quickly elaborate for the benefit of the delegates, the history of these approaches is that FTOZ is done for those tumors which are involving the upper clivus. Anterior petrosectomy is for those tumors which are arising medial and above the internal canal, internal auditory canal, without an extensive posterior fossa involvement. The posterior petrosal approach is for those tumors which occupy the upper and the middle clivus, whereas the combined petrosal is for those large tumors which can be covered by anterior petrosal as well as the posterior petrosal, both. Whereas another approach, which is we neurosurgeons very familiar with that approach, is the retrosigmoid approach. Now, this is a beautiful approach for the tumors which are mainly located in the posterior fossa, with some extension to the Meckel's cave, where we can do a suprameatal extension or a transtentorial extension retrosigmoidally, and then take out the portion going into the Meckel's cave. So with this background of conventional traditional skull-based approaches, I will sail you through the normal, newer paradigm of neurosurgery, which is the keyhole approach to deal with these tumors. So before I take you into this, one has to study the preoperative MRI very, very carefully. So what do we do? What do we study in these preoperative MRIs is the location of the tentorium cerebelli in the coronal scans and the location of the internal auditory canal. So if the tumor is located lateral to the internal canal, this means that this is probably approachable. This is definitely approachable through a retrosigmoid route. Okay, so this is the number one most important point while selecting the approach for these tumors. Whereas if the tumor is located medial and central to the internal canal, then this type of a tumor is approachable through the subtemporal approach. So this is one important decision-making process while you study the MRI of these tumors. So this was one good paper I came across from China, and this discussed about the treatment strategy for different petroclival meningiomas. The clival meningiomas, petroclival meningiomas, petroclivo-sphenoidal meningiomas, and sphenopetroclival. They divided these meningiomas into 6 categories. So the approach was depending on whether the predominant location of the tumor is in the posterior fossa, in the ipsilateral posterior fossa, in the contralateral posterior fossa, or the tumor is going extensively into the cavernous sinus or into the sphenoid. So depending on the extension of the tumor, they took the tumor out through the retrosigmoid route, through the transtentorial retrosigmoid route, or through the retrosigmoid intradural suprameatal route, or through the posterior petrosal route, anterior petrosal route, or combined route. So this is the conventional literature on the skull base procedures to take out these meningiomas were actually. So now, but with the advent of the operative findings and the technical advancements, especially advancements in optics, now that we have endoscopes as well as 3D endoscopes, now the conventional skull base approaches, which require long hours to do and which are quite morbid procedures, are now slowly turning into minimally invasive approaches to deal with these tumors especially. And keyhole approaches have been a boon to deal with these tumors. However, at some point of time, we do have to stage these keyhole approaches, but then it is also not a very bad bargain if we stage these keyhole approaches into 2, take out the front portion and then later on through the another keyhole in the same sitting, or maybe in a staged sitting next day, then we can take out the posterior portion through the posterior fossa. It is a wonderful bargain if we do that. And the beauty of these skull base keyhole approaches is that there is a less approach related morbidity. This is less time consuming access. This is the better cosmosis and the less temporal muscle atrophy if especially you do a subtemporal approach. And wound healing is better, especially because of the size of the skin incision. So the keyhole approach, we all know Alex Bernaski is a keyhole neurosurgeon from Germany. And then I had the pleasure of meeting this wonderful guy in 2007 in Jordan in a meeting. And unfortunately, he left us for his heavenly abode in 2009. And we lost this wonderful person and the wonderful surgeon. And the second, my personal friend and a very good human being, Charlie Teo, who are proponents of the keyhole neurosurgery, the foundation of which has been laid by Alex Bernaski. And needless to say, and these 2 gentlemen, they have been, they are the master pillars, masterpieces of doing the wonderful keyhole approaches. So what is the keyhole concept? And I would like to take you to 2 or 3 slides in introducing this keyhole concept. This is a beautiful concept in which there is a mobile viewing trajectory, and through a keyhole, there is a wide and multiple angles of vision which you can get through this small keyhole. And it is just like viewing the entire room through the keyhole. And howsoever, since this keyhole is very, very small, it has to be very, very carefully placed. And of course, you need image guidance, absolute necessity while planning your skin incision. The vision which you get is just like, shown in illustration. When you take your eye close to the keyhole, you can see the entire room. Your field of vision covers the entire room. And howsoever, some cases are not good for doing a keyhole, like, for example, superficially placed tumors, the convexity meningiomas, obviously. Howsoever, it is suited for deep-seated lesions, particularly apt for petroclival tumors. So somehow, if you cannot get a vision, you can use your 30-degree or 45-degree endoscope to visualize around the corners, as you can see in this small endoscopic video. And I will show you later on in my operative videos as well as to how to visualize these tumors and remove the rest of the tumors after that. So the workhorse of the keyhole approaches to petroclival tumors are the subtemporal transtentorial approach or the retrosigmoid approach. Maybe it can be retrosigmoid transtentorial approach or retrosigmoid intradural suprameatal approach, as I will be showing you shortly in my videos. So I have modified this chart into my preferences, my surgical technique to deal with these tumors. Like, for example, these clivus and petroclival tumors, I generally prefer doing by a keyhole subtemporal or retrosigmoid approach, whereas the tumor which is having a big component in the both in the middle fossa and the posterior fossa. Then I can stage the procedure into first do a subtemporal, and then later on in the same sitting or maybe next day, I do the retrosigmoid approach. So taking you through some of the, I have some time to show you some of the important the patients which I operated in the last years through a keyhole subtemporal approach. This was a pre-operative MRI and the post-operative MRI picture patient. Now this is another petroclival meningioma operated through the keyhole. You can see the complete excision of the tumor, another large petroclival tumor, and this is the incision. I will be showing it in detail in the operative video. And this is the post-operative CT, immediate first night post-operative CT scan of the patient. Another petroclival through the keyhole subtemporal approach. This is the planned incision. This is the craniotomy size, general craniotomy size in the keyhole approach. This is the immediate post-operative CT scan showing the complete tumor excision. A small video which I would like to share for a keyhole Kawase approach is now coming to the important aspect about the patient positioning. Patient position, this is the incision, which is about 4 to 5 centimeters inside, and this is the lateral position with head turns towards the head falling down towards the floor. And now this is the concept of the keyhole, that the keyhole covers the deep-seated structure, deep-seated tumors like these petroclival tumors, and this is the zygomatic line, and the meatal line ahead of this is the 4 to 5 centimeter skin incision. Now this is cutting of the masseter muscle and temporalis muscle, and lifting of the bone flap, and this is the size of the bone flap. Now you see this is the pre-operative MRI of this patient, and it is very, very the size of the craniotomy. Now, one important point before you proceed on to strip the dura of the temporal fossa is that you have to bevel this undulating temporal edge so that because you're not doing a zygomatic osteotomy, so you have to bevel this, and so that this beveling increases your angle of vision by about 20 to 30 degrees. A routine procedure of stripping of the dura from the temporal base, and then working in the interdural space. Now this is an interdural dissection being done for a Kawase approach or an extended middle fossa procedure. And this is the V3, and now this is the middle meningeal artery, which is being tackled over here during the process of further lifting of the dura from the temporal base. And this is the GSPN, and this is how it looks like. That is the greater superficial petrosal nerve. This is the facial hiatus for the geniculate ganglion while lifting the dura further. And this is the golden triangle, which we all call as Kawase's rhomboid, and which is being bounded by GSPN, posterior border of V3, petrous ridge, and the meatal line. So this is the area of your drill, and which is being drilled now, and this completes the extradural steps of your bony work. And then you open the dura of the temporal base, and you are on the tumor, and you start the tumor work. You do the QSAR, take the biopsy, and then decompress the tumor tissue. Now the important structure here is the fourth nerve, which you have to visualize and save. You will just now see it. This is the fourth nerve. You see, this is the fourth nerve, and you have to dissect it very carefully, and then save this important nerve. And this is the posterior cerebral artery, and this arachnoid tumor plane is very, very important, and you have to respect it and worship it like very nicely. You have to do a sharp dissection at places, and you have to do decompression and internal debulking, and then lifting of the tumor tissue so that it does not take important structures or damage important structures like perforators or superior cerebral artery or posterior cerebral artery over here. And this is an important perforator which is being very carefully dissected off the tumor tissue. And this is the dissection of the piece of the superior cerebral artery, which you see here, of the tumor tissue. So the decompression make the tumor more manipulating, more mobile, and lifting the tumor from the brainstem and from the important perforators. Now dissection of the superior cerebral artery, take this as superior cerebral artery, the PCA will be up and towards you in this case. And this is all a sharp dissection. Do not pull, always do a sharp dissection over here. You see that, you realize, you will know at any point of time, there is no lack of space while working through this keyhole. You have ample space, whatever you want to do, you can do with this approach. I always say in my lectures, with this keyhole approach, now this is the basilar artery, which is now slowly coming into view as you lift this tumor tissue from the brainstem, and slowly decompress the tumor tissue, burn tumor tissue, shrink the tumor tissue, and then lift it from the perforators and the surrounding important neurovascular structures. Take care of the arachnoid, which is very, very important. Worship this arachnoid. This is a great friend during the meningioma surgery. Basilar artery in full glory, and then dissection. Now this fifth nerve comes into view, and you have to separate this tumor from the fifth nerve and debulk the tumor again, make it manageable, make it more thin, and then dissect the tumor arachnoid and take care of the important perforators and important vessels, and while you lift the tumor tissue from the brainstem. This is the crux of your skull-based surgery. This is the crux of this beautiful petroclival meningioma surgery. Make the tumor more manageable. Do not pull at any point of time. Pulling is absolute no-no, because you can pluck a perforator from the basilar artery and then ruin your beautiful surgery. Now this is the last attachment which is being taken out, and this is the complete dissected fifth nerve, which is being preserved, stimulated at the end of the surgery. And then you see basilar artery here, superior cerebral artery, and the important perforators over here. And almost a complete excision of the tumor tissue has been achieved in this. And now at the end of the surgery, you take inside the endoscope, you see entire structures over here, basilar artery. This is the post-operative CT scan showing almost complete tumor resection. This is the immediate post-op CT scan. I always do routinely immediate post-op CT and immediate post-op MRI of the patients in order to visualize the completeness of the tumor excision. And sometimes in just simple cases, I do and prefer to do an MRI procedure. You see that the third nerve and the fourth nerve are intact in this patient. So coming to the retrosigmoid approach, quick glance over this beautiful retrosigmoid approach, keyhole approach of this patient. This is the post-op CT scan, immediate post-op first night video of this patient, showing no deficit absolutely. And this is the 1 month follow-up of this patient. And this patient had preoperative fifth nerve V1 palsy also, which is persisting after 1 month of surgery, but absolutely no neurological deficits whatsoever. Another retrosigmoid transtentorial approach taken out through a keyhole. And this is the first post-op MRI, day MRI, and the CT scans of this. Now, this is the transtentorial approach, and by cutting the tent over here, you can beautifully take out the tumor which is going supratentorially or even into the Meckel's cave. If you do a suprameatal extension, you see the facial nerve and the tumor, and over the tumor is draped the superior cerebral artery. So you have to very, very carefully, meticulously dissect the superior cerebral artery to avoid having an infarction later on in the post-operative period. And at the end of the surgery, you take inside your endoscope and see the tumor completeness of the tumor excision. Another tumor taken out through the retrosigmoid suprameatal transtentorial approach. You see the size of the skin incision in the retrosigmoid approach. Immediate first post-op night CT scan, and this is the first post-op night post-operative video of this patient. And this is the
योगेंद्र, ठीक है, दोनों हाथ ऊपर उठाइए, दोनों हाथ ऊपर उठाइए, उठाइए, ये वाला हाथ भी, ये वाला हाथ उठाइए, दोनों हाथ ऊपर उठाइए, उठाइए, ऐसे ऐसे.
At the end of the surgery, you take inside your endoscope and you see all the beautiful structures. The fourth nerve over here, the basilar artery, the superior cerebral artery, the brainstem, and the coagulated attachment of the skull of the tumor tissue over here. And this is a small video. I will just drag it fastly just in order to show this. This is the preoperative CT scan and the preoperative MRI of the same patient, which I showed the same slide just a while ago. And a retrosigmoid craniotomy, a usual retrosigmoid craniotomy is fashioned. And then this is the tumor tissue, which you visualize here, dissection of the arachnoid, and then dissection of the arachnoid tissue, and you see that's a superior cerebral artery which is lying over the tumor and needs to be dissected, hence to be respected very, very carefully in order to avoid post-operative venous arterial infarction of the superior cerebral artery. And then this is the facial 7th, 8th complex, and the tumor is being taken out from in between the windows of the cranial nerves and the superior cerebral artery. You decompress the tumor tissue, through the CUSA, dissect the superior cerebral artery and dissect it, decompress it again. Now cut the tent. Now this is the transtentorial approach, and you see the beauty of this transtentorial approach. Everything opens in front of you like a book, and you get a clear-cut picture of clear-cut view or panoramic view of your tumor lying in front of you, and you have to do little effort to decompress it again and make it more mobile, more manipulating. And soon you are going to see another important structure, which is the fourth nerve traveling over the top of the TA. This is the fourth nerve here, which is traveling through the top of the tumor over here, decompressing the tumor and retracting the tent after cutting it, and then decompressing again, cutting the tent again to increase the visibility of the tumor, and then lifting the tumor tissue, lifting the tumor from the brainstem, and then sucking it again. Now this is a very important thing. This arachnoid tumor arachnoid plane has to be respected and has to be very, very carefully separated. Otherwise, I mean, now the separation of the superior cerebral artery, which has to be very, very meticulous, and you have to respect the arachnoid plane between the tumor vessel, between the superior cerebral artery and the tumor. And this is the third nerve, which you see over here at the anterior end of the tumor. So at no point of time there is any lack of space in this keyhole approach, and the morbidity of these conventional skull-based approaches, it's hard to imagine, I mean, as to why these skull-based approaches may be even used. You can even stage this approach if at all it is a significant portion of a tumor is not reachable. It happens sometimes. The next slide I will show you as to what are the indications for a combined staged approach of these keyhole approaches. So this is the separation of the superior cerebral artery, and making the tumor small bit by bit, cutting it, sucking it, and then making it more mobile and separating the superior cerebral artery. Now these are papaverine soaked cotton patties, which I prefer to put while dissection of these. This is the third nerve, and separation of the tumor from the, and the basilar artery is coming into view slowly.
Sumit, can we just hurry up a little?
This is the basilar artery over here.
Sumit?
And there you go. It's been completely separated. The superior cerebral artery, it is pulsating well, and you have to place a gel foam soaked in papaverine over it to avoid this vasospasm, which may cause problems later on for the patient. And this is there you go, completely removing the tumor, and then this is a completed profile, a completed tumor bed, which is absolutely removed after the end of the surgery. And then at the end of the surgery, you take inside the endoscope and you see all the beautiful structures over here. This is the occipital lobe over here. This is the tent, and this is the third nerve over there. This is the fifth nerve. You can see all the, this is the tumor attachment over the, and the immediate post-operative CT scan showing complete tumor excision, and the immediate post-operative MRI of this patient showing complete tumor excision. And so now a couple immediate, just two more slides. I will complete it and wrap it up immediately. So this is the indication for a combined staged keyhole subtemporal approach and a retrosigmoid approach. Now that the tumor is going both directions into the supratentorial as well as the posterior fossa. And this is the patient who has come to us from outside. Somebody attempted a retromastoid craniotomy with outside. And this is the scan which we did at our hospital, and the patient was taken for a staged approach. First of all, the subtemporal approach was planned, and this was a total tumor excision through the subtemporal approach. The tumor was very, very hard, inconsistency, and intimately adherent to the perforators and the vessels. And this was the retro. After the second stage, the next day after the retrosegment approach, you see the complete tumor excision of the patient, of the tumor. Now, this is another such approach I did recently last week, and this is, you see both anterior and the posterior, and the tumor is going posterior to the internal canal as well. So this is a significant posterior fossa component also. This is a the first stage of the subtemporal approach was done, and this was a tumor excision, and this is the first post-operative evening after the surgery that the patient is slight third nerve palsy. And the pupil was reacting well, but slight third nerve palsy, which is temporary, I think, and it should recover. So the take-home message is that the petroclivals are formidable tumors to treat surgically, which are associated previously with high treatment-related morbidity and mortality. Massive skull-based approaches, in my opinion, are no longer required, and the skull-based surgeons all over the world are now resorting to more minimally invasive and keyhole endoscopic approaches for these tumors. And keyhole approaches therefore offer a rational and less morbid, better option. And these two approaches, the subtemporal transtentorial approach and the retrosigmoid, are the workhorse approaches for petroclivals. These two approaches are very, very common, and all our first neurosurgeons are very, very aware about as to how to work with them. Thank you so much.
Thank you, Dr. Sumit. But I think due to the paucity of time, we'll go directly to Dr. Vernon's talk, and then we'll come back for discussion for both these talks together. Dr. Roopesh.
Thank you, Dr. Sumit. That was a very good talk. And now I welcome Professor Vernon Velho. He's a professor and head of Grand Medical College, and delegates here. Doesn't need any introduction because he's a brilliant academician, and he has taken the department to great heights ever since he's taken over the department of neurosurgery at Grand Medical College. I welcome Dr. Vernon to give his talk on foramen magnum meningiomas, which yet another difficult meningioma to encounter.
Thank you, Roopesh, for the wonderful words. I'd like to thank Sridhar, my great friend, for inviting me, and also I'd like to thank Baxter for keeping up this educational program. So my topic today is foramen magnum meningiomas. So I'm going to move below Sumit. Sumit has covered the petroclival part. So these are also a difficult area. That's my hospital. So coming to these meningiomas, they account for around 0.3 to 3.2% of all meningiomas, and between 4 and 15% of all posterior fossa meningiomas. They are relatively slow growing, and the mean length of time since the patient presents is around 30.8 months. And they represent around 70% of the tumors around the foramen magnum. They're mainly intradural, but sometimes you can get an extradural extension, and rarely they might be entirely extradural. So what is a prerequisite for the treatment of these meningiomas? It is the perfect knowledge of the surgical anatomy. So basically, there are two main types. One is a craniospinal type originating intracranially and then moving down towards the spinal canal, or it could be spinocranial type originating in the upper spinal canal and then going intracranially. So ventral foramen magnum meningiomas, they originate from the basal groove at the lower third of the clivus and anterior to the medulla, and they project inferiorly towards the foramen magnum. Coming to spinocranial meningiomas, they originate from the upper cervical area and usually posterior or posterior-lateral to the spinal cord and project superiorly into the cerebellomedullary cistern. So coming to the foramen magnum, as we all know, one has to know the anatomy, the anterior border, which is formed by the lower third of the clivus, and the upper edge of the C2, and the lateral borders would belong to the jugular tubercles, the upper aspect of C2 laminas, while the posterior border is mainly the edge of the squamous occipital bone and the C2 spinous process. So this is just to show you how the area is pretty tight, and any tumor in this area will give rise to symptoms which the patient always presents with. And just to show you the anatomical relationships of the bone as well as the structures which are passing inside and out of the foramen magnum. So here we have the pictures which are beautifully described by Roton, where we have the relations posteriorly, anteriorly, and the lower one, which is D, which shows you the venous anatomy as well as the arterial anatomy involved. So what are the contents of the foramen magnum? They are basically the anterior and the posterior spinal arteries, the vertebral arteries and the meningeal branches, the lower part of the medulla, the lower cranial nerves 9, 10, 11, the roots of C1 and C2, cerebral tonsils, inferior vermis, the fourth ventricle, and they are surrounded by the veins and venous sinuses along with the jugular bulb. So this is when the different positions where one can see the foramen magnum. It could be either anteriorly, anterolaterally, posteriorly, and once in the anterior, you can see the vertebral arteries, which are mainly the V3 and the V4 segments, which can join in front of the medulla to form the basilar artery. So one has to be very familiar with this anatomy when dealing with tumors around this area. And here, the vertebral artery, which we would be concentrating on, is the V3 and the V4, the part of the vertebral artery which goes over the arch of the atlas and then goes into the atlanto-occipital membrane to enter into the posterior fossa. Blood supply basically is by the meningeal branches of the vertebral artery, the ascending pharyngeal arteries, and the occipital arteries. Infrequently, you might have meningeal branches which are coming from the pica and the posterior spinal artery and the V4 segment. So what are the clinical presentations? Basically starts with occipital headache, cervical pain, which can be aggravated with neck motion, coughing, and straining. And as the tumor grows, one may get sensory symptoms and motor deficits, which are mostly asymmetrical type of a weakness. And it's a classical U type of a pattern, inverted U type of a pattern, which is classical of an extramedullary intradural lesion. So coming to classification, they can be divided into the following. They can be divided based on compartment of development, intradural, extradural, or intra-extradural. And depending upon their dural insertion, it can be anterior, posterior, posterior lateral, and anterolateral. It also has a classification based on the relation of the vertebral arteries, which it could be above the vertebral artery, below, or on both sides. Now, these are different diagrams, and based on this location, one has to plan the approach to getting these tumors out. So the vertebral artery also plays an important role because many times these tumors might be encasing the vertebral artery, and one has to be very, very careful about it. So intradural meningiomas are the most common type, and they're mostly anterolateral. They are not purely anterior. Very rarely they would be purely anterior. And then we have posterior lateral tumors, and then pure posterior or pure anterior. So coming to investigations, one of the most important investigation is the CT because it shows you a good bone anatomy. It shows you the jugular bulb, and I find it more informative as compared to the MRI. The MRI will show you the relation to the spinal cord and the brain stem. And the other investigation, which is important of today, is intraoperative monitoring. A CT angio is very, very important to see the lie of the vertebral artery and also to see an anomalous course of the vertebral artery. So what's the importance of the radiology? It's to find out the nature of the tumor, its location, attachment, its relation with the cervicomedullary junction, and its caudal and rostral extension, and the position and the possible involvement of the VA. And the shape of the foramen magnum is important to plan your approach, and the dominance of the VAs, and the pattern of dominance of the venous drainage. So these are the various surgical corridors which one can plan depending upon the tumors. And most of the times, the meningiomas itself, the tumor itself, it gives you the corridor to the approach. As the tumor enlarges, the more bigger the tumor, more better the corridor. The more smaller the tumor, more smaller is the corridor. So if one can study this meningioma well on the MRI, on the CT scan, you can plan the corridor by taking the hints from the tumor itself. And that is what I take into when I study the MRI. You will find that the meningioma almost opens the door to your approach. So coming to surgical approaches, it depends upon the location, the extent, the relation of the tumor with the surrounding blood vessels, including the vertebral artery and the inferior cerebral artery. And this could be posterior, it could be anterior. Anterior now has become less popular, and we have lateral, then modifications of lateral, which could be far lateral, lateral suboccipital, or extended lateral transcondylar. So there are different approaches, but in my experience now, I have moved on just going down posteriorly in a midline approach and then moving laterally as and when required. So the goals of surgery would be a special consideration because of the vicinity to the brainstem and lower cranial nerves, removal of a tumor with lowest morbidity, and the approach should allow adequate control of the neurovascular structures without overexposure. So these are the different approaches which are described in books, and the anterior approaches are mostly used for extradural tumors rather than intradural tumors. But however, with the popularization of endoscopy, now they are giving the anterior approaches again a second look. So we are most familiar with the posterior approaches, which could be suboccipital, retrosigmoid, lateral, extreme lateral approaches. So these are the basic positions which one can use for the posterior approach, the anterior approach, or the lateral approach. And if it's a purely anteriorly placed meningioma, then one has to do a condylar drilling as well as have a far lateral approach. So this is the basic position for a far lateral approach, with the head slightly falling down and a bit lower down, something like the I would say park bench type of a position, with the space between the ear and the shoulder increased, and the muscle flap which has to be dissected, and the vertebral artery which has to be mobilized. And this is the way how it is mobilized and kept on one side, and the opening of the dura, and then getting onto the tumor which is more anteriorly placed. Well, these tumors, when during the excision, one can have complications such as hemorrhage, pseudomeningoceles. CSF leakage is a big problem when one goes far lateral, because closure of dura becomes a problem. So now I have changed my approach. I go more in the midline and then move posterior laterally. And of course, lower cranial nerve injuries and sometimes craniocervical instability. So these are some literatures, not many cases discussed in literature at this area. And these are some series by Dr. Sami Bertalafi. Again, not many cases in literature. So just to show you, this is an anteriorly placed meningioma where one can do it from a midline approach. The incision is slightly bigger. Unlike Sumit Sinha's keyhole approach, I prefer to have an adequately good incision where one can have a more lateral exposure. And I feel going from the midline and dissecting it in the subperiosteal plane, the muscle plane, one can get a better visualization of the vertebral artery. And once that is done, once you reach as lateral as possible, you can see the tumor come in front of you. So we can debulk it with the QSA and then gradually disconnect it from the anterior attachment. And that's what I was telling. Sometimes the QSA does not work, so you have to use scissors as well as the number 15 blade to cut it if they are calcified. And devascularization to the attachment of the dura is important, and then one can get the tumor out, and that's the preservation of the vertebral artery as well as the lower cranial nerves. This is another patient. This was operated by my associate professor, Dr. Rishikesh. He used the far lateral approach for this patient with a typical U-shaped flap, hockey stick flap as we call it. So here again, we're mobilizing the vertebral artery. And once that is done, then you can get a good exposure. The trick is to get as lateral as possible. And in my opinion, now you don't really need to go far lateral. Opening the arachnoid. These are the nerves. The tumor is within, anterior to this, so one can find your space between these nerves. And as far as possible, one should avoid retracting the cord. Try to debulk the tumor as much as possible with the suction. The number 1 also can be used to core the tumor. And then getting the tumor out gently. revascularization bit by bit, and working the tumor and getting the capsule towards you is very, very important. Sharp dissection as much as possible. And low bipolar coagulation is also very, very important. Otherwise, it keeps interfering with the intraoperative monitoring. So once that is done, the aim is to break this tumor. Sometimes you can disconnect the tumor from the base of the dura, and one can get the whole tumor out depending upon how it is attached. So gentle traction and a gentle tug and a piecemeal excision. And that's the patient. Follow up. And a gentle delivering of the tumor. So one has to achieve proper hemostasis and close in a watertight fashion. The dural attachment can be coagulated with low bipolar coagulation. And keeping everything intact is very important. That's the vertebral artery there. This is another patient, more posteriorly based meningioma, going more into the posterior fossa. So here we do a removal of the arch of the atlas after we have done an occipital craniotomy. Again, go as lateral as possible. This tumor is right on the surface, so it's easier to excise it in toto. One can excise it along with the dura. So you can almost do a Simpson's grade 1. So that's the exposure you need. So this is a midline approach again. And here we are going laterally. So I feel one should not compromise on the opening of the dura. You should have good dural opening so that you can get control of the tumor. Here the attachment is posterior lateral, so one can go all around. And once that attachment comes out, then the tumor can be dissected from the arachnoid plane beautifully. So the arachnoid plane is your guiding light to meningioma surgery. So here we are excising this dura along with the tumor. When one gets the chance to excise it in toto, one should take it, because when you have too much of blood in the field in this area, the patient can post-operatively get a lot of adhesions. In the arachnoid space. So as far as possible, you should try and get these tumors in toto. So avoid retracting the medulla, avoid retracting the spinal cord, and keep your traction on the tumor as much as possible. And the most important thing after this surgery is to close the dura. So here we had to take a pericranial patch, which you can harvest initially. Now we have dural grafts. We have bovine pericardial patches, which we use, and that's achieving hemostasis. And here we are stitching a pericranial patch for duroplasty. This is another patient whom we just operated. So the CT angio plays an important role for you to decide which side to go and which side to avoid. This is the position we use. A slightly bigger incision so that we can retract the muscle and go in the subperiosteal plane. Here is mobilization of the vertebral artery here. So this is the groove, the arch of the atlas. There's always a plexus of veins around the vertebral artery. And this is drilling the arch of the atlas, just like a laminotomy. We place this back along with the occipital bone and going as lateral as possible with the drill. And this is the vertebral artery, which one has to mobilize. So from the midline, it is possible to go as lateral as possible and even drill the condyle. That is what we are doing here. After mobilizing the vertebral artery. And there, once you open the dura, you will see the tumor to one side. So the important point is while seeing the MRI, you will always see these tumors sort of move to one side, and that's the area one has to approach. So this is fluorescein, which can be helpful to see if the vessels are feeding the tumor. You can also see a beautiful dural enhancement there. And if you see the medulla and the cord, they do not take much of fluorescein. So it can tell you what's the pattern of the vasculature. It can also tell you how much dural base you have to coagulate and cut. And it gives you the pattern of the venous drainage too. So here we are separating it from the dural attachment. And the aim is to make the meningioma into a neurofibroma. So once you have converted the meningioma into a neurofibroma by devascularizing its attachment, then it comes out like a neurofibroma. So here we are going first to the base. Coagulating the attachment again. Sharp dissection. And separating it with the arachnoid from the nerves, low cranial nerves. Getting off the dentate ligament. Many times the dentate ligament is attached to the tumor. And what I use is a sharp hook to sort of give a little bit of tug to the tumor. That comes in very handy. Instead of holding it with a big tumor forceps, a sharp hook allows you to manipulate the tumor without any pressure on the cord. So if you see this tumor is going down, so one can deliver it once it is detached from the dural attachment as well as the arachnoid. And a gentle traction with this sharp hook. Last attachment. One should be very patient while handling the last attachment. So always be patient, don't be in a hurry to pull and push. And then the tumor can be delivered beautifully outside without any traction or any pressure on the cord. And that this we could achieve complete this closure without any graft. So we went in slightly laterally rather than going in the midline, the dura opening. And we could achieve a watertight closure without any dural patch, pericranial patch. So this is the patient post-op. She was bedridden, but now she's improving in power. She's moving her limbs against gravity. And that's the post-op scan. This is another patient whom we had operated. Sometimes it is better to leave some tumor if it is attached to the vertebral artery. Here, it's not 100% complete excision. There is a little bit of tumor which we had to leave, which was calcified and attached to the vertebral artery. So I think one has to know what to do where. And to conclude, these tumors are challenging due to their vicinity to the brainstem, vertebral artery, and lower cranial nerves. The approach should be chosen depending upon the location, extent, and accessibility of the tumor. The contrast MRI, CV junction, 3D CT angiogram is very essential for planning the approach. And the microsurgical excision using intra-neuromonitoring results in complete cure with less morbidity and mortality. Thank you for your patience.
Thank you. Thank you very much, Dr. Vernon. It was very, very illustrative and very lucid presentation. You showed various approaches, right from midline and far lateral approach. So I believe that your practice, you prefer mostly midline approach.
Yeah, I have changed.
So,
I have
okay.
changed.
Whereas your colleagues, I think, prefer far lateral. So is that you have some strategy in your department, or it's a consultant, your wish?
I give them the freedom to choose what they, I don't emphasize that you have to do only what I do.
Yeah. So only surgical strategy is that most of these foramen magnum meningiomas, they're very firm, unlike other supratentorial. Invariably, they are very, very firm tumors. And if they are small, so is it safe to go midline? Because you don't really, it will reach a lot of traction on your middle. So in a small meningioma, you still prefer a midline, or you go far lateral?
You can go far lateral even from midline, in my opinion, because sometimes you can even take the dorsal nerve roots down, okay, and use them for traction. Use the dorsal nerve roots, 1 or 2 dorsal nerve roots. All you need is a little bit of access to get to the tumor. Once you get to the tumor, you can work the tumor towards you.
So does the vertebral artery position influence your approach if it is a true midline?
Not exactly. You have control of it. If you have control of the vertebral artery, the important thing is to get control of the vertebral artery initially.
And in your practice, what is your incidence of your lower cranial nerve paresis post-operatively?
I have not seen much of it. Okay, that's what. Because if you tend to have good monitoring, and if you tend to use more of sharp dissection and less coagulation, then the chances of lower cranial nerve involvement and palsy is less.
I think Dr. Sridhar is raising. Yeah.
Vernon, just a question. If you go midline, how do you get access to the control of the vertebral artery? Because that's easier when you do the U-shaped incision and then you've got the muscle exposure going right lateral.
Because see, in my opinion, if you go as lateral as possible, I don't know, if you're doing, we do CV junction surgeries, and every CV junction surgery, we always see to it that we are able to see the vertebral artery. So that—
No, at C1, C2 or at the foramen magnum?
At C1. So first, you got to identify the vertebral artery at C1. You got to see it at C1 when it is going inside the foramen magnum. Because what happens with far lateral? With far lateral, you are going vertebral artery first. You're going to see the vertebral artery first. And that's the time when there are chances that you might injure the venous plexus. So when you're going in midline, you can dissect as lateral as possible.
Do you turn the patient stable after you reach the tumor?
Yes, you can do it intra-op also, if required. You always have the patient in a position where he's strapped, he or she is strapped, and one can tilt the patient as you like.
I had a question to Sumit, because I don't ask him before. Do you use a routine lumbar drainage LP?
Well, actually, because of shortage of time, I couldn't mention it in my presentation. I don't use lumbar drain, but what I use is if a patient has a preoperative dilatation of ventricles, especially, then I choose to do an Omaya procedure before my definitive surgery, because that helps me, especially when I'm ventilating my patient overnight, especially after a long surgery, when a patient surgery gets over in the evening. So I prefer to put in Rumaya in this circumstances, which helps me bail out, especially during the overnight when the patient is electively sedated and ventilated.
But where are you putting the
But I don't have to ever anytime convert it into a permanent shunt drainage system.
You mean to say you do a frontal butthole, put a Omaya chamber?
Yes, yes.
That's interesting.
Have you encountered any temporal lobe edema, temporal lobe swelling where you had difficulty in your minimally invasive approach?
It does not happen. It does never happen. You have to keep certain things in mind, especially while doing a keyhole approach, in order to avoid this eventuality. It can definitely happen, especially if you're not very careful about doing. See, we have to understand that keyhole does not anyway mean applying a retractor system to the brain. Keyhole means knowledge of a perfect anatomy, and before we go in, having a patience to drain the CSF in order to relax the brain structures. So do not apply brain retraction system. The brain retractor is only to support the temporal lobe, and be very, very careful of the vein of Labbé, which is especially in the subtemporal approach, which is traveling nearby posteriorly, and do not happen to damage it. So if you are careful about these points, then especially in a keyhole approach, you will not never in any case end up having a temporal lobe swelling or temporal lobe edema.
Sumit, how do you deal with suppose you have entered and you find that the brain is full, then what is your strategy?
When I started doing this keyhole about some six or 7 years ago, I mean, this was quite an eventuality which used to happen actually, and it is quite an intimidating situation to a neurosurgeon, and anyone can really understand as to the horrific situation when you open small and then the whole of the brain bulges out. I mean, it's a neurosurgeon's nightmare, but it will. The keyhole neurosurgeon has to have a patience. I mean, it will never happen in any of these cases if he learns only 3 words: patience, patience, and patience. Immediately after opening a craniotomy, making a craniotomy, before you open the dura, there is a certain rule. Do not open the dura all over the brain. So suppose if you are operating on a medial sphenoid wing through a mini-turinal approach, you have to open the dura only over that small little area where the tumor is, where the tumor brain interfaces, and then search for the CSF cistern or a CSF space or a Sylvian Fisher arachnoid. You cut that arachnoid, gently release the CSF, sit down for 5 minutes, slowly retract, don't apply pressure, release the CSF, and when you spend these good 5 to 8 minutes releasing the CSF from the cisternal spaces, invariably in about 99.9% of the cases, the brain will become lax, and it will allow you to give so much of a space that you will be able to do the decompression of the tumor and saving the brain structures without any retraction even. And it happens. It happens.
With Sumit, this is very, very important that when you're doing especially a subtemporal approach, you have to have the patience to allow the brain to relax. You shouldn't be in a hurry to get to the lesion because the normal brain has to be preserved. So I think this is a very, very important point, and I think that's the crux to any reaching any deep space. That's very, very important. So I think if Roopesh, would you like to wrap up?
Yeah. So the last 2 hours, we had a very, very interesting session on meningiomas, which is, we know skull-based meningiomas are very challenging and very tough lesions. So starting from olfactory groove meningioma, I think what we need to understand from Dr. Sridhar's talk, the take-home message will be, there's a lot of now enthusiasm from moving from midline to lateral approaches, especially if the tumor is not very big. And the care is to be not only the tumor removal, but the reconstruction is paramount importance as far as olfactory groove meningiomas are concerned compared to any other skull-based meningiomas. Of course, one need to be very careful how they deal with the frontal lobes and the anterior cerebral arteries, especially when front olfactory groove, especially in large meningiomas. I think now The resection of the frontal lobe, which was a practice initially, I think now we have given up, and more now with the good relaxation techniques, good anesthesia, we are avoiding. At the same time, now there are many surgeons who have moved from microscopic to endoscopic approaches of olfactory groove meningiomas, especially those smaller ones which does not have much edema. Moving forward from olfactory groove meningioma, we had Dr. Tetsuro speaking on medial sphenoid meningiomas, which again yet another challenging topic, and he had nicely shown beautifully how dissecting out from the internal carotid artery and how he manages the optic nerve going towards the corridor between the optic nerve and the carotid artery. At the same time, tuberculosis meningioma. So here, the extradural clinoidectomy gives a lot of space, and he has very much emphasized on that. So that really gives a basal approach, and you are also devascularizing the tumor, getting to the base and removing it very nicely. At the same time, in tuberculosis meningioma, drilling of the optic canal again improves the visual outcome extradurally, so that the falciform ligament and the optic canal doesn't act as a hinge. Otherwise, many times we have a lot of visual optic nerve disturbances postoperatively. And next we had Dr. Dilip Panickar speaking on parasagittal and falcine meningiomas, and a lot of scripts on how do we manage the bridging veins, which is one of the most challenges when we operate on these difficult tumors. And so we should be extremely careful and dissecting using sharp dissection. The preservation of the bridging veins of paramount importance. Of course, one can take very small veins which are more anterior. However, every attempt should be made to preserve these bridging veins. And what he stressed very important is that never be aggressive on the sinus. If there's a small, if it is very adherent, it's better to leave a thin rim on the bridging vein and on the sinus rather than encountering problems postoperatively. Of course, we had discussion on the molecular profile of meningiomas in his talk, and he had shown up H3K27E, and also we have EGFR, followed by the third mutation and the indications for radiosurgery or radiotherapy, upfront radiation in grade 2 and grade 3 meningiomas, especially when they have third promoter mutations. Moving forward, we had a very nice talk by Dr. Sumit Sinha. Of course, we couldn't have much interaction immediately, but it was a very, very nice talk, moving from macroscopic approach to keyhole approaches, which is a new dawn. We had a lot of debate on what the main crux in petroclavial meningiomas are, the approach what we choose. So we had anti-petrosectomy approach, retrosigmoid approach, and so a lot we can debate on which is the better one. Of course, now more and more retro posterior fossa approaches are now coming in more than the anterior approaches. But however, it depends on the site. But we had Dr. Sinha speaking very nicely and enlightening his beautiful videos on using keyhole approaches, and even these difficult meningiomas can be removed using these techniques. And finally, down the line, we had the inferior most foramen magnum meningiomas by Dr. Vernon Velho, again beautifully emphasizing the importance of the approach. Even he has shown that midline approach are also equally good. We are all thinking more of far lateral approaches. So, but however, one has to be very comfortable in choosing the approach, and it's a surgeon's choice and the comfort level of the surgeon in deciding how to approach these again difficult meningiomas. The most important problem in foramen magnum meningiomas is that how we deal with the vertebral arteries and how we handle the brainstem. So without a retraction on the brainstem, especially cutting the ligamentum denticulatum, and how nicely we go doing sharp dissection, shrink the tumor, and then get it out through the small crevices without disturbing it. It's very, very important to avoid postoperative morbidity. I think it was overall a very nice session on meningiomas, skull-based meningiomas, and I think it should be closed now. I will give to Dr. Sridhar for his closing remarks on this.
So thank you all, everybody. And just if you go to the chat box, we would request you all to just give a feedback, all those who attended, so that we can know how to make these tumor Thursdays better. So I'm just going to end by saying Happy Diwali to everybody, and next month perhaps we will be delaying the Tumor Thursday by a week, because we are having our normal the Thursday comes, we are having the Asian Congress of Neurosurgeons, which is there. So perhaps the next, or in December, it will be a week later. But we will be continuing the Tumor Thursdays. There are a lot of tumors that needs discussion. But thank you all very much and have a lovely Deepavali weekend. And thank you all.
Thank you.
Thank you all so much.
Wish you all a happy Diwali also.
Happy Diwali to everybody.